This is really the trials we have at MD Anderson, though I will speak about a few trials that are at other places. It's not easy for any of us, you guys or the providers necessarily, to know what's going on everywhere at every time. But I do have a good relationship with Dr. Sato and Carvajal, and so we're often chatting about what each of us are doing. So here's some of the trials we have at MD Anderson, or did have, or will have. So nivolumab, ipilimumab, Grant is right. That is, I often hear people say nivo-ipi doesn't work for uveal melanoma, and that's not an accurate statement. It does work. Whenever somebody says it doesn't work, I always ask them, who told you that? Where's the data on that? There's no published data about nivo-ipi, and so nivo-ipi, actually the only trial being run in the US that will answer that question is this trial. It's almost finished. We have a few spots left, and we think we'll finish hopefully before the new year or shortly thereafter, meaning we'll enroll, and then it will be, some time after that before we see the results. At the time we designed this trial several years ago, nivo-ipi was not yet approved, and so it was a really good option. And then it became approved for skin melanoma. But the FDA, when they approve things, don't say, this was not tested in ocular melanoma, and so it's very reasonable for an oncologist locally to try that. And then if they don't get a response, then that's where we start to hear, oh, it doesn't work, it doesn't work. But that office visit of one patient or two patients, that's not a clinical trial, methodical way of knowing if it works. Nivo-ipi in skin melanoma has about a 67% response rate, and in uveal melanoma, like we see across all of our trials, most of the time we see that there's a 5, 10, 15% group where the treatment works. And the idea being eventually we may have 6 or 7 different trials where it works 5, 10% of the time. And if we can drill down on who are the 5 or 10% that this drug works for and this drug, then we can do more patient matching up front. We can say, hey, you have the type of immune system or mutations or tumor burden that matched these responses. Why don't we try this treatment? Because I don't think we're going to get to a place where we are in skin melanoma where we have 2/3 of patients responding, at least not yet. So nivo-ipi is one trial that we're doing. It is only at our hospital on a clinical trial, but you can get that anywhere as standard of care. It also comes with the National Cancer Institute's only funding for a uveal melanoma project. It's funding some of the research associated with looking at the tissue on the patients who enroll in nivo-ipi, who do well, who don't do well. We want to study the tissue and start to figure out what are the characteristics of responders and non-responders. And then intermittent selumetinib is a MEK inhibitor. It's an oral pill. That trial has, it's open right now at 3 centers, 2 in New York, and both in New York City, and then 1 in Houston. So MD Anderson, Columbia, and Memorial Sloan Kettering. We're waiting for UCSF to join, but I think they're still a little bit behind. So right now, each site gets their own spot at a enrollment spot, so there's a rotating waiting list for that trial. It can be anywhere from 2 weeks to 6 weeks. There's BET inhibitors, which is an oral therapy. Our phase 1 department had that trial, and right now they don't have any spots. We have a PV10 trial. By the way, the ones in red are MD Anderson only. The black ones are at other places. PV10 is a skin-directed liver injectable treatment that we'll go over. You guys have, I heard, had a pretty lengthy discussion about Dell Cath already, so you're aware of that. Engineered T cells, and there's more than engineered, they're endogenous T cells is what I should really call it, against MART1 and SLC. And then there's different types of combination immune therapy combining PD-1 or PD-L1s with LAG-3. There's the antibody drug conjugate glumbatumab, which is hot off the presses, was just presented last week in Australia. And then the MEK inhibitor plus AKT inhibitor was a study we finished a couple of years ago. It's in its final analysis stage. And then the glumba study is leading into more combination therapies. And then we're designing an adjuvant trial for the high-risk class 2 patients, a prevention trial, where we would give them a year's worth of nivolumab plus ipilimumab. It's still in the design phases, but we're hopeful that in less than a year we could be up and running. So throughout this slide deck, I have a few little cartoons. When you see this, that means it's an intravenous therapy. So it goes through an IV, typically in your arm or chest. If you see a pill, it's an oral therapy. And then if you see a liver, that's the liver, by the way, if you see that with the stomach next to it, then it's a liver-directed type of therapy. So if you see that on the slide, that kind of tells you what kind of treatment it is. And so Nivo-IPI is an infusional therapy. The study was amended in the last year to allow prior immunotherapy. As I mentioned, when we first designed this trial, it was during a time when immunotherapies were not approved in melanoma. And so we were taking essentially people who had not had exposure. And now that patient is really hard to find because the drugs are approved. And so any skin or uveal melanoma patient will have exposure to some checkpoint blockade typically. And that's perfectly fine. We're looking to see if the combination can rescue somebody where a single drug did not work. But we are not allowed to take anybody who's had prior combination. The combination is given once every, can you see my pointer? You can't see it now, huh? At the bottom, those circles, it's given once every 3 weeks for 4 doses. And then the arrows just signify the every other week dosing of nivolumab. And this first tumor assessment doesn't happen until that first star, which is at 12 weeks. And so it's quite a long period before you know if the treatment is at least helping. And with immune therapy, it's not uncommon for that first CAT scan to look worse because your immune system has to grow up and recognize cancer. And that may happen in 12 weeks, but it may take longer. But meanwhile, the cancer has continued to grow. And so that first CAT scan could actually look worse before your immune system catches up and looks better. So this is a bunch of targeted pathways in cancer and in uveal melanoma in particular. The GNAQ, GNA11 is there. It's at the top or at the cell surface, as we think. If that blue kind of double barrier is considered the lining of a cell, that's where GNAQ and GNA11 exist. And from there, they can fire off, I know you can't see my pointer, they can fire off all these different pathways. And MEK inhibitors work over here on the left side of the screen, and then BET inhibitors work in the nucleus, which is a little component farther inside the cell. So those are a couple of areas that we've been targeting recently. Selumetinib is one of these MEK inhibitors. We've been studying them for quite some time. The most recent way we're studying it is on an on-off schedule, so intermittently. And the reason being that just like an antibiotic, if you took an antibiotic continuously, you could develop resistance to it. That same thing happens in oncology, whether it's MEK inhibitors, BRAF inhibitors, breast cancer medicines, lung cancer medicines. And so an on-off schedule, at least in mice, has demonstrated that every time you take away the drug, the cancer relaxes and does not become as resistant to the drug. Now, it can still develop resistance, it just takes a little longer. So the way we're dosing this drug, because we're doing it on-off, you're actually able to go beyond the typical tolerated dose because you're not taking it every day. So we're going, plus 100% on the dosing, 3 days on and then 4 days off. So it's usually a Monday, Wednesday, Friday on, and then Thursday, Friday, Saturday, Sunday off. There are some strong visual side effects, though. In other words, in your good eye, you can develop some blurriness, and it can be permanent blindness. So it's a dose-limiting factor right now. I've had patients who it's twice-a-day dosing. The morning dose, they already know that they're getting fluid building up in their eye. So it can be very tough to maintain this drug. So we're still in that dose-finding period. This drug is given, a cycle is given, it's considered once a month, and so we start looking every 2 months to see if it's helping. The BET inhibitor, BET is another pathway. It's inside the nucleus of tumor cells, and it looks important in uveal melanoma. So there have been several BET inhibitor studies across the country. At MD Anderson, it's not run in the melanoma department. It's run in a department called Phase 1 because this pathway looks important for multiple types of cancer, not just melanoma. It's a daily drug, and this drug has been promising enough that they're now looking to combine it with MEK inhibitors for diseases such as uveal melanoma. So we hope to see those studies soon. PV10 is a liver-directed therapy. And PB10 is something called ROS Bengal. It's an ablatant. It's basically a tumor cell disruptor. This treatment is really only effective for patients who have predominant liver disease, which we know is uveal melanoma. And it's injected through the skin into the liver. And for this trial, they're only going to choose one target lesion, inject it one time, and then a month later take an assessment of it. At that time, another liver lesion can be chosen for injection. So it may be ideal for somebody with just a few dominant liver tumors rather than a bunch of little ones. And ROS Bengal is actually named because of its very fuchsia-like vibrant color. It's a very fluorescent kind of red color. And we've used it in skin melanoma for some time. What happens when you inject a tumor cell is this drug gets taken up inside the cancer, and then inside the cancer it's unstable and it starts to rupture. And so it causes the cancer cell to break open. And here's a skin melanoma patient that was injected. It actually leaves a pretty fuchsia-like red stain on the skin for a period of time. Typically when I see it, I see the injection, this kind of hot pink red looking appearance for about 2 weeks or so. And then it fades and goes away. But that's a sign that the drug has actually ruptured out of the tumor and is sitting now in the surrounding tissue. We think the same thing will happen when we go through the skin into the liver, that you'll actually get some pinkening of the skin or fuchsia-like changes. And actually, it probably will not be abnormal for you to urinate some pink or maybe red-like looking urine for a few days. And so we'll counsel everybody on that. So Dell Cath, you guys spoke ad nauseum, probably not necessary for me to go into detail. The real issue that we've had, and the reason we stopped running it, is that it's limited. The FDA forced Dell Cath's hand with limiting it to patients who only have one site of disease outside of their liver, and that's wishful thinking. Typically, if there's a site of disease outside the liver, it's not that you have one deposit in the lung, you might have multiple. It's not that you have one lymph node or one soft tissue, you often have multiple. And so we were doing this game of picking off tumors to get them down to one outside the liver, and by the time we tried to get them on Dell Cath, there were more, and for some reason it's the FDA, it's not Dell Cath mandating it, it's really the FDA, which is kind of short-sighted. Liver is the site where we need control, not the lymph node and not the soft tissue. So we screen failed about 30 patients for this because of that limited tumor requirement. And so because of that, and then for other sort of resource issues, it was just a lot of resource utilization when we couldn't find the right patients. So it's not an option right now at MD Anderson. I know this trial's at Moffitt, and you heard from Dr. Ferris and some other places in the US with the randomization factor. Of course, it's available in Europe and some other places not on a clinical trial. You probably saw the schema of it. So T-cell therapy, adoptive cell therapy, is also called tumor-infiltrating lymphocytes. And this started at the National Cancer Institute in the 1970s under Steve Rosenberg, who really the basis of this was there were some melanoma patients with metastatic disease who had spontaneous regression of their cancer without any treatment. And it was really sort of telling, what's causing this spontaneous regression? Well, it must be their inherent immune system. And so he went looking inside the tumors, and indeed there were these infiltrating T cells in melanoma tumors, and in fact we now know it's inside of a lot of cancers. And those infiltrating T cells are actually capable of recognizing that there's a problem and secreting killing factors. The problem is that it's just a numbers game. If you have several million cancer cells in the body, your body's not making T cells quite that fast. And so he said, well, why don't we manipulate this outside the body? What if I take one of these tumors, and so you have to have a surgical removal of a cancer nodule, and for uveal melanoma, I'll tell you, it's got to be about an inch worth of tumor. Little dots of tumor in the liver or little dots on the skin, it's not a successful way because there's just not enough T cells in those small quantities of tumors. What happens is you take the tumor, And then in the laboratory, they're essentially manually chopped up or digested and put into these long, large 96-well plates. And those plates are really meant to put as small amount of tumor as possible with the lymphocytes or T cells that it carries. And then by the end of 2 weeks, the cancer cells are dying in each of those little wells, and the T cells are overgrowing. And so you have basically manipulated the environment so that there's very few cancer cells with even a small amount of T cells so that the T cells can do their job. And you, in that plate, you're also feeding it growth factor for the T cells so that the T cells are energized. So when you do that and the cancer cells die off, those T cells then we hope can be expanded and start to replicate outside the body, what they can't do inside the body because there's too many competing forces. So we replicate them up to at least 40 to 50 million, which is really the strong definition of is that a successful amount of T cells to freeze. I will caution you though, there are some places that grow T cells that don't have a cutoff, and so they'll claim, 90% successful growing T cells, or 95%, but that's because they don't have any sort of defined cutoff. If you take 1,000 T cells and grow them to 2,000, they would say that that's successful growth. You need 50 million frozen for them to actually be in sufficient quantity for us to give back to you. The treatment is intravenous, hence our little cartoon nurse here, and you get the T cells back inside the hospital with some growth factor for your T cells. It's like miracle grow, if you will, for the T cells. And that all happens inside the hospital. So you're in the hospital for 7 days getting chemotherapy. It's typically fludarabine, Cytoxan, 2 days of Cytoxan followed by 5 days of fludarabine, so 7 days of chemotherapy. And that's, there is a technical purpose for that chemotherapy. It is to eradicate your bone marrow. It's considered non-myeloablative chemotherapy, but it's lymphodepleting. And so your bone marrow actually does take a hit during that time, as evidenced by the fact that after you get your T cells, you have no white blood cells, you have no platelets, and you have no red blood cells for a period of about 2 weeks. So your bone marrow is recovering from all of that chemotherapy and repopulating. What we think will not repopulate without these T cells given to you is your white blood cell population. So the chemotherapy is really strong enough to permanently eradicate that white blood cell population to the point where we actually erase your immunity to things like measles, chicken pox. I guess we're all too old to have had chicken pox vaccine, but measles, mumps, polio, we're actually eradicating your memory for that. So we have to, at some point down the road, re-immunize you against those. So that's about a 30-day process in the hospital. You're in the hospital for a week getting chemo. You get your T cells, you're there another 2.5 weeks until your bone marrow is safe. You're in something called protected environment, where we come in with a mask, gown, and gloves because your immune system is just not ready yet. And you have no platelets and you have no hemoglobin. And so you're essentially a bone marrow transplant for that 30-day period. And then you're able to, once the blood counts recover, get discharged from the hospital. You will be on antifungal medication, antibacterial medication, and antiviral medication for at least 6 months. Again, this immune system that we gave you fights cancer, but it does not know how to fight bacteria or fight a virus that you might pick up. So it's pretty intensive TIL type therapy. And here's some examples of skin melanoma responses to TIL. So you see in the left-hand side, you see some lung tumors that got smaller. You see that dermal or subcutaneous nodule that got smaller. And we have some lymph nodes in the pelvis that got smaller. I didn't have an example of a liver one to show you. And at MD Anderson, we just haven't treated enough uveal melanoma patients to have enough of a cohort to report. So the question is, first of all, do uveal melanomas have TIL? The short answer is yes. We published a paper in the spring in Oncoimmunology that shows absolutely uveal melanomas have TIL. And the first thought was, people always say, well, this disease doesn't respond to checkpoint blockade, maybe because there's no T cells, but that's not the case. There are T cells. They're just, if you look in panel B, they're a log or 2 lower than what you see in skin melanoma. So skin melanomas will see sheets and sheets and sheets of hundreds of T cells, and we'll be lucky if we see 100 T cells in a tumor. The other thing that we look at is how many times outside the body are we able to expand T cells to that 50 million mark? mark, that threshold of needing to be frozen. Skin melanoma, if you look at a series of, now we've been doing it at MD Anderson about 13 years, so our numbers are up to about almost 700, 655 here. If you look, we're about 2/3 of the time successful in growing skin melanoma T cells. If you look in the modern era, the last, say, 7 years where we've been refining our techniques, that number's above 70%. So this number's dragging down a little bit by some old cohorts. The uveal melanoma is pretty contemporary. It's really only been harvested since I've been there. And so these 33 patients that were harvested, we've only been successful about 45% of the time. Number one, because there are log less amounts of T cells in the uveal melanomas and cutaneous melanomas. And the second reason is it's not often that we send you guys off to surgery for removal of a cancer nodule. What's more common is somebody will send you to IR for a biopsy of the liver, and that biopsy is really small. You know, under a microscope or on your hand, I could show you, it looks like a grain of rice. And so that's really different than what we get in skin melanoma. When a skin melanoma metastasizes, a surgeon is really ready to go in there and get the little, you know, ping pong ball or golf ball sized tumor. So size does matter, and when we start looking, we've not really successfully grown anybody in under about an inch. So that's where my threshold for size comes in. It's about 2.5 centimeters or an inch of tumor. So that's T cells. Uveal melanomas do have them, and we think we can grow them. Now, we have figured out a new technique to grow, and actually it turns this pie chart on the left to 100% successful. The last 5 uveal melanoma patients we've harvested, at the time we're harvesting something out of your liver or lung or wherever, we ask you, can we take a piece of this and use it purely for research? The rest of it is yours. If they grow, they're yours, but can we better our skills? And the last 5 patients that let us do that, we tried a new technique of growing T cells, and it was 100% effective. It's 100% effective in skin melanoma and some of these other cancers where the T cells are hard to grow. The problem is the grant that we have for growing T cells only covers the old method. So it doesn't have the funding to cover this new method. And so we're either going to have to wait, 5 or 10 years until the NCI grants a new TIL funding application, or we get a donation in a few years, or we just have to wait for a pharmaceutical company to jump in. And pharmaceutical companies are not terribly incentivized to fund TIL trials because the process doesn't really use their drugs. The process uses your immune system. And so Merck would say, what do we get out of this? So if we fund it, where is our drug even having an indication here? So this is one of those areas where finding a pharmaceutical sponsor is really difficult. And we would like to use this new method, but there's just no way right now in human-grade T cells to do it. We can do it in the research lab all we want and just verify that we can do it, but we can't give it to humans right now. It's several million. We think it would take like an endowment, probably of $10 million or so. Growing a patient's T cells is anywhere between $40,000 to $70,000, depending on how intense it is. And then, it depends on how many patients we're talking about, research nurses and things like that. So we think it would be, that $10 million, by the way, on a pharmaceutical budget. Is there pharma in the room? Do we have pharma? No? Okay. I don't want to talk about their budget with them sitting right here, but $10 million on a pharmaceutical budget is nothing. It's a drop in the bucket. They gave me $1 million to run that Nivo-IPI trial back in 2011. They gave us $4 million to do a more recent uveal trial. So they'll spend money. It's just they would not be incentivized to fund this trial. And $10 million you can't get out of the federal government. The NCI and the NIH is slashing their federal funding, and the biggest grants that come out of federal funding, like an RO1 or a PO1 project, are in the maybe $1 million range, but they're not in the amount to fund an actual clinical trial. So we do have other flavors of TIL, as Hartmut had alluded to, and so traditional TIL, you just get your T cells back. It's this hospital maneuver. We digest your tumor, grow up your T cells, and you get them back. And that's kind of the vanilla flavor of TIL. But we are developing other flavors of TIL where we take, if the red cells are the good T cells, the TIL, we put these antennae on that are able to block some of the repellents that the tumors can secrete to push the T cells out. So we add these extra, surface things to help repel those. And those are that's considered viral engineering to do that. And so that's a different flavor of TIL, and that requires sometimes a different quantity to be frozen down. And sometimes it also just requires that a patient have accessible tumor, meaning it can be biopsied over and over, because the idea being you want to make sure that these TIL are actually going to that cancer and not somewhere else, which is right now the problem with CAR T cells is you can't necessarily direct them to just go to the cancer. So engineered cell therapy, or as I said, I really like the word endogenous a little bit better. Endogenous cells are cells that we would actually get out of your bloodstream rather than from a tumor. So Hartmut had shown that's another way to grow T cells. And that pheresis maneuver, leukapheresis, if we're being technical, taking out the white blood cells, those T cells we look for are the activated T cells. They're activated, but they're not yet antigen specific. So they don't yet know, which of those Halloween colored proteins that is the enemy. So outside the body, we tell them what the enemy is. And so that's considered more of an endogenous cell, it's your own, and then outside the body, we tell them what the problem is. Now, you can only do that so many different ways. That's not the right way to say it. I guess you can't grow up T cells outside the body that it will be a perfect fit for the whole human population. So what we do is we do it by HLA typing. HLAAO201 recognizes a specific sequence out of the MART1 protein, and we know what sequence that is. And so you can design an HLAAO2 restricted T cell to recognize a specific sequence of the MART1 protein. Because there are so many HLA types, there's 1, 2, 3, 24, 22, and all these, and it's O208, O203, O201, we would never be able to make each of those matching. That would be a perfect world. That would be an amazing to have like a robot do that. But there's no way, so we go with the most common HLA types that are out there. And this one requires HLA-A0201, and we do think it's the most common HLA allele in Caucasians, maybe about 25 to 30%. And it requires that your tumor actually express this MART1 protein. So that's a stain we have to do on the tumor. So we need blood to make sure you have the right HLA type, and then we need tumor to check that it's MART1 positive. Sometimes your original pathologist will have said, it's SOX100 positive, MART1 positive, this is melanoma. Sometimes they just say SOX1 positive, melanin positive, this is melanoma, and then we have to do the MART1, in which case the insurance may not pay for that test of a few $100s for us just to verify that it's a MART1 expressing tumor, and then that would be billed. It is pheresis for your T cells, and then it takes about 6 weeks or so to grow up those T cells outside the body. And then this type of way of giving T cells requires low-dose chemotherapy. It's typically a couple of days of chemo outside the body, in the outpatient setting. And then you go into the hospital the day of your T cells, basically. You get your T cells by vein, and then you have 2 weeks of daily outpatient visits where you're getting interleukin-2 in the chemo suite, which is the Miracle-Gro. And your first assessment is typically at 12 weeks. Again, this is just your immune system kind of goes down, we give you your T cells, the immune system comes back up, and that whole time your cancer can be growing. And so that's why sometimes we push that first assessment so far out, is to see if we've had enough time for the immune system to work. This trial, as opposed to 30 days in the hospital, it's 30 days in Houston, but most of that time is spent as an outpatient. And then we are engineering against a new protein called SLC. And SLC, it's SLC45A2 specifically, and this is a hepatic route of administration rather than an intravenous. It's the same concept. We take your blood and we make sure that you're HLA-A0201 positive, and we just put through an amendment to take A2402 because we're able to grow up T cells in that restricted HLA type as well. 2 days of chemo, 2 to 4 days in the hospital, and then the same 2 weeks or so of outpatient interleukin-2. There's outpatient and inpatient with this, that little short inpatient hospital stay. And then in the dose expansion, we'll actually give you the T cells and then give you 4 doses of this anti-CTLA-4, which is ipilimumab, on an outpatient schedule. So you'll get the first one the day after your T cells and then the rest in the outpatient setting. And we think it's IPI that helps keep these T cells alive rather than the PD-1s. So this trial is hepatic route of administration, and so you'll get a catheter placed into your groin, which will lead up to the liver. So you'll be flat. You have to be able to lay flat for about 12 hours. You may not be able to, you can't bend your knee, certainly can't bend your hip, and you'll have a catheter in your bladder. So interventional radiology will put that catheter in, then you'll come back to our floor, and then we'll administer the T cells. We're trying to get them to go in over about an hour or so. And the T cells, the catheter will be delivered, if it's possible, our guys will try to lean it, in the direction of where your tumors are. But catheters and circulations, it's not always possible to do that. Meanwhile, these T cells should get everywhere. So even if they're not able to get it directly where a tumor is downstream, they'll get it in the right side of the liver or the left side or the common hepatic artery, depending on the tumor distribution. So that's TIL. So I'll just talk briefly about a couple of completed trials. NCI 9445 was a trial we did with multiple centers, Emory, Memorial Sloan Kettering, Columbia. This was a trial of a MEK inhibitor versus a MEK AKT. I don't know if you can tell, that's meant to be a scale at the bottom. Essentially, at the end of this study of about 40 patients, 20 on each arm, we saw that there was equipoise. It's not that MEK plus AKT really even did any better. We had less responses, but more importantly, the time to progression was the same, just under 4 months in each arm. And so it really didn't look like the addition of AKT did what we thought it was going to do, which was going to give us stronger responses. And so this has really stopped further development. This AKT inhibitor has actually been pulled off clinical trial investigation for toxicity as well. It's all AKT inhibitors are toxic. They give you mouth sores and things, and we did see that. So this trial should be published soon. And then just a week ago now in Australia, I presented the final results of this glembatumumab vedotin study. And glembatumumab is a novel kind of drug called an antibody-drug conjugate. It's intravenous. It's a kind of targeted chemotherapy, you can think of it. And those of you from last year will remember this kind of illustration. You have a tumor cell, and you have a protein on the cell surface, and the drug recognizes that protein, is internalized, and then the tumor is killed from the inside out. Then you have some loose chemotherapy floating around, and it can come in contact with any of the cancer that maybe wasn't expressing the surface protein. And so what we saw was there was about 1/3 of the study population had disease stability for over 100 days. So their CAT scan actually showed stability for 100 days, which is considered a long period. Longer is always better. And then of our responders that we had, the median duration of response was about 8.6 months. So kind of on par with some of the other things that have long duration. Here's a couple of examples of patients. This is one of our partial responders. He had that tumor in the kind of left side of the liver, if you see. And then it essentially went down by more than, the criteria is it has to shrink by more than 30%, but his went down by about 44%, making him a partial responder. And then we had another patient who, this is a lymph node you're looking at that's inside the circle, and you can see that it squished down quite nicely. That actually only met criteria for stable disease, but this gentleman, this stabilized for so long and he had no new cancer appearing that he was on study for 426 days, so well over a year. So the Glumba study is actually leading to some new addition, and we're actually looking at glembatumumab in combination. We're combining it with the MEK inhibitor, and there's been a concept approved to do that at several hospitals in the country, as well as combining it with PD-1 inhibitor. My lab is actually looking at some of those tissue samples from those patients that did that trial. We had a biopsy before we started and after one cycle, and we're looking to see if there was more immune cells after one dose because the tumor actually opened up. Did that introduce more more T cells to the environment, and would PD-1 be the right combination? Both of these combination concepts have been approved by the drug company and by CTEP, the National Funding Agency, and so we hope to have those trials in the next year. I think you guys talked quite a bit about IMC-GP100, so I'll just leave it at this. This is Dr. Shustari's presentation at last year's Society of Melanoma Research. Oops, sorry. This was the phase 1 where he described the uveal cohort. And essentially, this drug works in 2 ways. It actually, the T cells, or I should say the T cells work in 2 ways. The T cells can actually recognize any proteins that the tumor might be showing on its surface. But more importantly, the T cells can bind to the drug, and the drug can bind to one of these surface molecules. And so that T cell redirection can cause a secondary type of response. Now, GP100 also exists on a lot of normal cells, and so the problem is when the T cells start trafficking to normal cells, you can get untoward side effects. Some old GP100 studies back in the day did lead to blindness because there's GP100 on our some of our melanocytes in our eye. So we have to be careful about how much we introduce an immune response that's not specific for cancer. It's just specific for a protein that might exist on normal cells. So this drug actually had some prolonged stable disease as well, as you can see, over 24 weeks in some cases on this study. And so it's currently being studied versus IPI or Pembro or dacarbazine. Not our favorite control arm, but we just need somebody smarter talking to these guys over there. Or we need somebody smarter at the drug company making decisions, is what I should say. We're all saying it to them. And I just want to point out this one takes HLA-AO2 restricted as well. So the portion of the IMC-GP100 that attracts the T cell requires HLA-AO2. And then also hot off the presses, this was presented in Australia last weekend by Sophie Paperno-Newman from Institut Curie in France. They have a protein kinase C inhibitor, and the GNAQ pathway, again, at the cell surface, protein kinase C exists right there in the pathway, and it can have downstream signaling of other uveal melanoma proteins. And so protein kinase C inhibitors have been in development for some time, and she showed a couple of slides here that showed some responses in the lungs and the liver. And essentially the study is ongoing right now at the recommended dose escalation level, which is 300 milligrams twice a day. They went far beyond that dose and found low blood pressure to be a rate-limiting issue. So they have openings for 12 more patients across Europe and Australia. They are in talks. This is a Novartis drug, and they are in talks to combine it with a MEK inhibitor. MEK is never going to die for us. I think we're going to try to combine it with everything. And the problem is the US FDA doesn't like this toxicity profile, and so I'm not sure we're going to have this option in the States. The FDA keeps saying there's too much of a heart toxicity with MEK and protein kinase C, and they're not giving Novartis very many options. So I don't know if we're going to have combination options with protein kinase C in the future. So that's all I have as far as overview of trials. And I guess we'll leave it at that, open it for discussion.
Yes, I'm going to start throwing. After this,
afternoon lulls, people gotta wake
after
up.
this, we're going to go and have a break.
Yes.
All right, so which is good. So I'm going to ask the first softball question to Dr. Sapna, please. So we found out that about 20% of our audience has been diagnosed with uveal melanoma within the past year to 2 in this group. So we heard a lot of very high level data, and for the new patient, it's a little overwhelming. So can you walk us through, if I have metastatic disease that's diagnosed at wherever I live, how do I get myself into a clinical trial? What do you as the oncologist look for to guide me? Can you give us like a very introductory experience into that?
Yeah, I mean, I think the thing that will happen is you'll end up mostly at a regular oncologist office who probably doesn't specialize in uveal melanoma, because there's 5 of us that do, basically, maybe 4 of us. And so you will they will tell you, oh, it's a type of melanoma. Okay, I'll check for this BRAF mutation, which doesn't exist in uveal. We'll try PD-1 inhibitors because they're the greatest, newest thing. And then in the meantime, it won't really work, and they'll get the sense that maybe it's not working, and then they'll say, you need to go see a specialist, and they'll send you. So that's often how I get a lot of my referrals, is the oncologist saying, hey, this didn't work, or even the patient getting a sense that I don't think this is the right treatment for me. So then it's a little hard, and that's perfectly fine that somebody's already had pre-treatment. In fact, that's so normal these days that we account for that. When I write a trial, I try to be pretty liberal with the inclusion criteria. I don't try to exclude anybody because of bad labs, although some of that's driven by the sponsor of the trial. If you have disease in your liver, we tend to take you even if your liver enzymes are up to 5 times the normal limit. We don't require a whole lot of brain imaging, brain MRI, this and that, which is more common in other trials. Skin melanoma is one of the most common cancers that goes to the brain, so a brain MRI is written in for all of their trials. But there's no point for us. It's written in for TIL, so if you ever come for TIL, I'll tell you, hey, we got to get this brain MRI because it's just a piece of the whole melanoma program. But we try to just be really kind of liberal with the inclusion criteria. And then the most important is to really explain what the travel schedule is like back and forth. Clinical trials cannot, really none of the ones that we do for uveal can be administered by your home doctor, even if we're using drugs like Ipi/Nivo. And the reason is those drugs are coming for free from the pharmaceutical company, and so they're called investigational, even though they're identical to the FDA supply. An investigational drug supply can only be dispensed from an investigational pharmacy. And so for that matter, even if we're giving you something that your home doctor can give most of the time, I'd say 90% of the time, it has to be given at MD Anderson. The one exception would be that endogenous cell therapy for the SLC. I think we figured it out that the home oncologist can give that ipilimumab at home if need be.
So,
yeah.
Dr. Patel, so I live in a small town wherever, and I've gotten a whole bunch of CT scans and MRIs, and my doctor says I need to go see somebody. Is it reasonable to, can I send my information into someone so I don't have to make the trip to one of the 4 people or one of the other centers, or could I go to a local academic institution or something like that, and then they contact you? How can I kind of work my way through that system?
So most of the hospitals will take self-referrals. So you would just call Sato's hospital and say, hey, I need to speak to Renee. I want to become a new patient. His office, and it's because he has Renee, who's really kind of a gem all on her own. She and him are able to do consultations without seeing the patient. Our University of Texas system precludes us from doing that. Our malpractice doesn't, cover all that. So we cannot do any sort of email, phone, or remote consultations. It has to be an in-person. But sending the discs ahead of time is huge, because if you send the images ahead of time and the new patient office or whoever puts them in the system, then that team can at least look and start to say, okay, I see the pictures. Is there anything we can offer, or should we stop this patient from even coming all the way out for a conversation? And we've done that a couple of times, but that's awkward too, because it's awkward for an office to call somebody who they've never met and say, hey, we got your data, we don't think you're a great patient. What does that even mean, So the best thing to do is, if you have an oncologist or get into an academic center, ask the simple question, how many times have you treated this? What's your success rate been? And are you opposed to sending a referral in so I can see somebody who specializes in this? And nobody should be offended when you ask for a second opinion. If they're offended, then something else is going on.
I would agree with that. I think that, especially for rare tumors, it would behoove the expert locally to be able to send forward. We have a question from the audience, and I'll get back to Hartmut for this.
Thank you so much for presenting, both of you. And actually, there's a reason that I call Renee Zelinsky Saint Renee, because she is absolutely the most wonderful cancer navigator I've ever met in my whole entire life. So, but that's a little off subject. So I wanted to ask about the TILs in the research I've been doing. So I know that it's HLA 20201 positive.
TIL doesn't have an HLA restriction.
The leukapheresis.
Oh, the endogenous cells, yeah.
Right. So that's 100%, like, right now, that you have to have that in order to do that, same as the GP100.
Right.
Got it. Okay. I was just curious.
Because they're enriched to the marked only, right? And the TILs, we have a mixture of many different TILs for potentially different antigens.
Got it. So TILs is open to people with different HLA types.
Yes.
Sabrina,
Perfect.
can you
Thank
toss
you.
that over there?
Yes.
And while it's being tossed over there, I'm going to ask Hartmut a question. So as a cancer navigator, can you briefly tell us, how you, if I called you and said, and you, instead of giving me this entire lecture, which I might be overwhelmed with, how would you help me navigate to get to a trial or to help me decide my options? What do you add to this equation?
Well, the biggest thing that we do when patients call us, the first step is we have to analyze the medical records in detail. So we work directly with the hospitals wherever the patient is coming from. We analyze those because the treatment history and the disease history and what has been done is instrumental in pairing a patient to a clinical trial. And that allows us actually in real time. I'm actually critical against online trial matching companies and you name it, artificial intelligence apps where you type in the medical records and out comes the cure. I think that's a huge overpromise because what the biggest hurdle is, finding a trial is a big hurdle that matches, but getting the patient in a trial, because as we are working with the trial coordinators and everything, the health can change. The trial enrollment, the NCI match trial, even study coordinators, for example, at hospitals don't know that the sponsor just changed the criteria. And while they're screening the patient, it's actually the patient is not eligible any longer. And that can cause huge frustrations. And so it doesn't work on the artificial intelligence computer program. It has to be real time because of the enormous quick change that we experience, especially in the health status.
So you're taking all this data that the patient is providing you and trying to sift it down and then look for actual...
Exactly, yeah. So our focus is really the treatment navigation because cancer navigators do exist at hospitals. They help navigate within the hospital system, which in itself is very difficult, right?
Absolutely. Question over here.
So just going off of Sabrina's, this actually isn't my question, but for the TIL, is there any HLA testing? I know you don't need to be positive for whatever that number is, but is there other blood or HLA testing that needs to be done too?
Yeah, there's a lot of blood that for all of these that end up getting done. You have to be screened for HIV, hepatitis, all these other things. As we start to expand your immune system, we have to make sure that those other things don't get out of control. If you do leukapheresis, we have to make sure we're not putting a virus, through the blood machine. So there's a whole host of viral exposure studies and blood tests that get done. HLA does get done as part of TIL, but it's not a requirement to, we will test you and we need the result, but you don't have to have a certain HLA to be eligible for TIL.
We're coming up on a break.
For patients who have failed things like Yervoy, would you say stay away from similar monoclonal antibodies? Like if you had bad colitis or autoimmune type things, is it reasonable to move on to another monoclonal antibody?
Oh, the problem is really the recommendations to oncologists is if you've had a serious autoimmune or immune-mediated toxicity, the whole class of drugs is to be used with caution. But, sometimes that means walking a fine line because what else can you do in some circumstances? But I have
Okay.
I had a comment I just wanted to add to Hartmut's comment about artificial intelligence. I agree that you can't necessarily trust a computer to pick out what's right for you. Have you guys gotten foundation medicine testing done? Has anybody gotten it done? And so I don't know if you guys have read on that cover page, most likely, more than likely, you guys had a GNAQ or GNA11 mutation detected. And on that very front cover page, it will say, GNAQ, the drug that matches to you is trametinib. And that's not accurate. I mean, trametinib, just because you have GNAQ doesn't mean trametinib will work. It doesn't mean that the trial is out there for you. And trametinib is an FDA-approved drug for skin melanoma. So what has become a recurrent problem, and I brought it up to Foundation Medicine, but they don't want to change their algorithm, is if you came to me and you said, but look, this form says trametinib's the right drug, I demand you prescribe this. So we have done it. And then, of course, what happens is the insurance will say, this is an FDA-approved drug. Show me that they meet the FDA-approved criteria. BRAF mutation, previous therapy with the BRAF inhibitor, something like that. And we can't prove it because this is uveal melanoma. So that computer matching is flawed in and of itself. It will say on that front cover page, you had a GNAQ, GNA11, here's the right drug for you. And it's not, the insurance company doesn't feel that way, and probably your oncologist doesn't feel that way either.
We're going to take 2 questions before the break, and then the experts will be available as well. The microphone's there, and then we'll go here, and then we might still get to you. Okay, so we'll start over there.
I came in a couple minutes late. I don't know if it was covered, but for the services of cancer treatment Navigator, is there a cost associated with that?
Yeah, so we are paid by the patients, and it was very interesting to figure out how to do this. And the reason why we decided to have it patient covered, a big portion of our work is independence, and independence allows us to really work with a patient and identify the treatment and help sequence the treatment. We don't treat ourselves, we send to physicians, right? And sometimes a clinical trial is not an option. So we work a lot in the off-label arena. So we recreate certain trial settings on an N-of-1 basis. You need physicians who are willing to do that. Usually those are investigators around hospitals around the country. But you direct the patient towards a approved trial, approved drug that is available for another cancer, but not for this cancer. If we would be a non-profit organization, many non-profits receive funding from pharmaceutical industries, so there would be a huge conflict of interest for that reason, and that would not allow us to freely to navigate what we think from a scientific perspective makes sense.
Mm-hmm. And where can we get information on costs?
It's absolutely individualized. Okay. So we have individualized contractual agreements. Some patients come to us and say, hey, I found this treatment options in so-and-so. Can you evaluate it for me? How much would it cost? How much will it take you? So some engagements are 3 hours, some engagements are 20 hours.
So it sounds like a conversation to have with Hartmut offline, but that's a good question. Ma'am?
Yeah, I have a question about the oncologic, the BT, the one that you said you do only to the liver.
The PV10.
Sorry?
PV10.
PV10.
Uh-huh.
So why would you do it only to the
liver and not like when we saw the cutaneous example? Somewhere, in other sites of metastases.
That company's already done it in those other sites, and they see that it works. But for this cancer in particular, they're wondering if going deeper into an organ will have the same immune trafficking effect as it does in the skin. There's many things we've injected in skin metastasis that have or have not helped.
Yeah, not necessarily skin, but it could be, I don't know, pancreas, for example, or the lung, or...
Their rationale was really to go for the organ site that was the most deadly in this cancer, and so they're trying to control it in the liver. Now, if there's proof of principle there that it works in that deep visceral organ, it's quite possible we could convince them to start injecting some other organs.
Okay. Yeah. And what is the success rate of the response rate for the TILs?
TILs, we haven't treated enough uveals.
Okay.
Last question, Martin.
I just go back to the statement you made that you did 5 trials and they were 100% successful and it will cost $100 million. So why is not efforts made in that direction if you know it's successful?
Oh, we're definitely trying. We write probably a grant every couple of months trying to get it funded. And, when you write away for grants, they can't all be identical each time because you have to explain to a granting agency, what have I written what are my other grants that are out there that if I get funded, now 10 agencies have funded the same concept and it's overlapping effort. So you have to kind of make it a little bit different each time, or you have to let sufficient time pass. And the truth of the matter is with the federal government, you were talking about Dr. Rebus's trial, he probably has updated clinicaltrials.gov, and then the government takes like 120 days to update their own website, So same, we submit grants typically on these different cycles for the government, and it's about 10 months before you know if it's funded or not. So just as you find out it's not funded and how to make it better, you package it up again and then wait 10 more months. And the other thing is these grants go in against breast cancer grants. and prostate cancer grants and lung cancer. And there's always an impact statement you have to write that if successful, this project will have this effect. And we know how to write that. I have federal uveal funding, so I know how to write that to get the message across. But imagine what the breast cancer person's saying. Yep. If successful, I've saved 15,000 lives a year,
Holly,
200,000.
I'm going to suggest that for next year's program, that we may even have a little breakout session to better understand the funding challenges, because I think what I'm hearing from lunch and with your question is, how come? Why not? And I think that I think we understand the why not because we have to kind of take that step. But for our community, I think that would be something that some people might be interested in hearing about. So maybe we'll put that on the agenda for next year.
Possibly could be mobilized.
Now you're talking. Now you're talking. So we'll go from there. So to be fair to the break, we're going to take a break now. Please stampede Dr. Patel and Hartmut as well. But thank you for your attention, and thank you for the two great talks we heard.